All right, we're going to talk on the cardiovascular theme. We're going to talk specifically about managing antiplatelet therapy. And in the context of discussing this, I have the same disclosures. We're going to continue kind of our discussion of the pathophysiology of atherosclerosis and why antiplatelet and anticoagulant therapy is important and why stopping it could be a problem. So to do that, we're going to need to talk about the indications for antiplatelet monotherapy and dual antiplatelet therapy. We'll talk about the epidemiology and pathophysiology of major adverse cardiovascular events, MACE we talked about. Again, we're going to focus on the 2024 AHA guidelines, which are out just recently. And we'll talk about bleeding and thrombosis and how we balance these risks, right? It's really about balancing thrombosis and bleeding risks. That's how we're going to come to an answer. When it comes to antiplatelet agents, I have them listed here. There's a series of them: aspirin, clopidogrel, prasugrel, ticagrelor. Cangrelor is an IV agent. The real important thing to think about here is, or to know, is that the first three agents are all irreversible inhibitors of platelet function. Ticagrelor is reversible. Cangrelor is IV. It's reversible. Reversible in the sense that it doesn't cause permanent damage. It doesn't have a reversal agent per se. And the other is that all of these agents have a relatively similar antiplatelet effect. And the first two, aspirin and clopidogrel, are probably the most widely used. You probably believe that clopidogrel causes more bleeding than aspirin does. I'm going to show you data today which says you're probably not thinking about it correctly. Okay, now, what are the indications for antiplatelet therapy, both dual and single therapy? In red are a bunch of arterial thrombotic conditions, starting with acute coronary syndromes, PCI, etc., atherothrombotic stroke. All of these are high thrombotic risk conditions. Antiplatelet therapy is very important for high thrombotic risk conditions in the arterial vasculature bed. And when it's very high, you want dual antiplatelet therapy. And when it drops down, single antiplatelet therapy is fine. And what really the idea is here that the intensity and the duration of antiplatelet therapy should be proportional to the thrombotic risk. You can see there's some other indications there are lower risk, and you only use single therapy for them. Now, when it comes to thinking about bleeding and thrombotic risks, if you look at this graphic on the left-hand side of the slide, when the event occurs, when the thrombotic event occurs, your bleeding and your thrombotic risks are highest. Your bleeding and thrombotic risks are higher. And over time, both risks diminish. Both risks diminish. And over the blue curves, which are the thrombotic risk, you see this is just stylistically. Every patient has their own trajectory on both of these things. How fast and how low the thrombotic risk gets is dependent upon the patient's condition. And how fast and how low the bleeding risk gets is also dependent on the patient's baseline factors. And for some patients, the bleeding risk is below the thrombotic risk, and for others, the thrombotic risk is always higher. And you have to assess each patient differently. On the right-hand panel is the data about dual antiplatelet therapy. How long should a patient who's had a PCI have dual antiplatelet therapy? This is a little bit controversial. It's not exactly clear, but what's becoming more and more clear is that after 12 months, there probably isn't much benefit, if any. And these data are taken from randomized trials in which patients had completed their 9 to 12 months of dual antiplatelet therapy. They did not have a problem, and then they got randomized to either continue their dual antiplatelet therapy or get clopidogrel alone. And what you can see on both of these graphics, one is showing you the MACE risk, the other one is showing the bleeding risk. When you went to single antiplatelet therapy, in this case clopidogrel, not aspirin, clopidogrel alone, both the bleeding and the MACE risks were lower after 12 months. There was no benefit from a MACE point of view in continuing dual antiplatelet therapy. This is important when patients are going to come for surgery and they're still on dual antiplatelet therapy 3 years later, okay? That's how you need to think about it. Now, what is the optimal duration of dual antiplatelet therapy? Again, this is a little bit controversial. How long? We talk already about the AHA guidelines about at least 6 or 24 months, depending upon the condition. There is unclear, should it be 3 months, 6 months, 12 months, depending on the patient. What's clear is that if it's less than 12 months, you can reduce the bleeding risk, but it's not clear that less than 12 months is better from a thrombotic risk. Now, here's some data I think you want to pay some attention to, and that is if you were looking at clopidogrel versus aspirin for extended secondary prevention of PCI. So if someone's had their dual antiplatelet therapy, and now I need to pick an antiplatelet agent long-term for somebody after their PCI. Again, this is a randomized trial. Patients had their dual antiplatelet therapy. They had it for 6 to 18 months. They didn't have a problem. And then they got either aspirin or clopidogrel alone, and then they were followed out. And they had outcomes were MI, stroke, readmission, ACS, death, and major bleeding. And perhaps to your surprise, you'll find that patients who got clopidogrel had less risk of bleeding compared to those who had aspirin. Less risk of bleeding. Okay? So same thing from a pharmacology point of view, and I'm a platelet person, there is no evidence that clopidogrel is more potent as an antiplatelet agent than aspirin is. And these clinical data would say, from a clinical bleeding point of view, there's no evidence either. Okay, let's talk about the pathophysiology of ACS and PCI. And I just want to pause for a moment because I know that's going to blow your mind. And that is when I'm talking about monotherapy, aspirin versus Plavix. Not together. Obviously, together it's different. But if you look at them alone, there isn't any evidence that clopidogrel, it causes more bleeding than aspirin alone. Okay? Now, let's talk about the pathophysiology. So it's important to understand that atherosclerosis, when you have an ACS or a PCI, the risk of another event, the thrombotic risk, is a time-dependent process, right? You have a type 1 MI, plaque rupture, you have a very thrombotic condition, platelets had started adhering there, they close off the vessel. Okay? The endothelium is injured. You have this now acute MI. Same type of process happens in stroke. You have an embolization from the carotid plaque, or you have peripheral vascular disease, or you have stent thrombosis. These are very similar types of pathophysiologic processes. And then this disrupted plaque or this disrupted endothelium produces a prothrombotic, pro-inflammatory state. And it takes time for that state to resolve. It doesn't just go away because you put a stent in. And it doesn't certainly go away if you haven't put a stent in. It takes time. And patients usually have more than disease in a single vessel of their body. It turns out that this isn't a single vessel disease. Everyone knows that. Atherosclerosis is a systemic disease. And you sometimes have a culprit lesion, but all of these lesions are in various states of disrepair in the body. And it takes time for them to repair themselves after someone has had an acute coronary syndrome or a stroke. And here's now the therapeutic implication, is that we use antiplatelet therapy while the thrombotic risk is high. If you take your time, you let the patient be anticoagulated or antiplatelet agents, the condition resolves itself. The plaques become more stable, less unstable. The stent, if you had a stent, it endothelializes. That endotheliumized stent is now less thrombotic, and then you can reduce the antiplatelet therapy. But this takes time. This takes time. Now, what is the most important factor in getting these atherosclerotic plaques stable? It turns out the most important thing is getting your cholesterol down. Ample evidence that lowering LDL cholesterol leads to plaque stabilization and regression. And there are a lot of agents that do that, statins, the PCSK9 inhibitors, they do that. Other piece of evidence is what exacerbates that condition is high LP(a). Now I know Lon checks these things, but most people don't. And it turns out that that actually can make your plaques more unstable over time. So what you need is time for your plaques to become stable. That's how you get into a low thrombotic risk. And the left panel shows you how, depending upon how high your LP(a) is how much plaque and unstable plaque develops. And then this data I think is important as you think about, a patient who comes who's had a acute coronary syndrome, again, the cardiologists are way ahead of the perioperative folks on this. They're interested in understanding what is the state of the plaque. And it's not just the culprit lesion that matters, it's other lesions too in the coronary vascular bed. And this is a study. They looked at patients who had an MI, they underwent a PCI, and they looked at the plaque burden and the stability of that using a PET CT. And what they were able to do is define unstable plaque or high plaque activity from low plaque activity. And then they followed the patients over time based upon this test. And they said, who's going to have more cardiovascular events? And those who had the high plaque activity had more events based upon this scan. Again, these are not data that we in the perioperative period see, but I show these to understand the pathophysiology is that just because you had an MI and now you had a stent doesn't mean all your plaques are stable. Doesn't mean that. Just meant that that culprit has a stent in it. When it comes to antiplatelet therapy, again, it's time dependent. So we know that the way the process works is you have an event, your plaque is unstable, you're a very prothrombotic and inflammatory state, and we put on antiplatelet therapy. When the risk is really high, as it is right after the event, whether you have an acute coronary syndrome or a stroke, then dual antiplatelet therapy is helpful. And you can see from these curves, right, they bend. They bend. You can see that the lower curve is DAPT in both, so dual antiplatelet therapy. The most benefit happens early on because that's when you're most prothrombotic and most pro-inflammatory. And then you still continue to get benefit, but the benefit subsides over time as this thrombotic state resolves. So you don't need to be on dual antiplatelet therapy forever. And you see the time horizon is a little bit different. It's a short time period for stroke, about 3 months, and it's a longer time period for acute coronary syndrome, with or without PCI. Now, we know that patients who've had a PCI do come for surgery. And we know that if you've had a prior PCI and you come for surgery, your risk is elevated. And we have a 2% suffer, 4 to 5% of patients are going to have non-cardiac surgery within a year of a PCI, and the risk of having an MI is pretty high in those patients. And 20% of patients are going to undergo non-cardiac surgery within 2 years of PCI, and again, the rate is pretty high for having an MI in those patients perioperatively. And the same thing is true of stroke. Stroke is not benign. Obviously, it's not benign if you've had it, but that risk persists. If you've had a recent stroke, your risk is elevated for a substantial period of time. And this is showing you at the 30-day incidence of death after a stroke perioperatively, and it diminishes. In this case, it's in reverse order from bottom to top. But as you become further away from your stroke, your risk goes down, but it's still elevated. And that's true, again, for just stroke or stroke plus death. So time matters here. You need time to resolve the condition. And I already showed you this slide again, really important, that your risk of having death after a recent MI or acute coronary syndrome, with or without a PCI, again, it doesn't matter, is elevated for anywhere between 6 to 12 months after the event, and for stroke, it's somewhere between 3 and 9 months until you return to baseline. Again, as I showed you these data, again, whether you look at the UK data or the US data, same pattern. So why is the risk of perioperative MACE higher after an acute coronary syndrome, stroke, or PCI? As I've been saying, you have this unstable plaque. It takes a while for it to settle down. It's an inflammatory disease. It takes time. You could also have incomplete endothelialization of a stent. It's not, I mean, that's part of it too, right? If you have a fresh stent, now you have unstable plaque in general, and you have a stent that's unendothelialized, very thrombotic. And if you throw on top of that, in the perioperative period, if I decide I'm going to take away someone's antiplatelet therapy, now I'm throwing fuel on the fire. And it turns out that when you cut somebody and you operate on them or they have trauma, you're inducing a prothrombotic, pro-inflammatory state. And there's a lot of pathophysiological processes that occur in someone who's been injured. Obviously, there's a direct injury to the vasculature. There's increase in platelet activity, increase of procoagulant proteins, et cetera, et cetera. So you're now, again, throwing fuel on the fire of someone who already was in a baseline pro-inflammatory, pro-thrombotic state if they had an ACS or they had a stroke. A couple cases just for you to contemplate. 64-year-old man, hypertensive, hypercholesterolemia, coronary disease, had a drug-eluting stent 1 year ago for stable angina, refractory to meds, Good exercise tolerance now. He's on the drugs that you've seen. He now needs a lung resection. He's on aspirin and Plavix. What's the best strategy to manage his antiplatelet agents? You see a number. Stop both of them, stop one of them, continue them, etc. How about this patient? 66-year-old woman. She's hypertensive, a diabetic, has peripheral vascular disease, coronary disease. She had an acute MI, and they put in a bare metal stent 2 months ago. Now she has a right colonic mass. That's why they wanted to operate on her. That's why they put in the bare metal stent. She's on aspirin and Plavix. Now, before we go into this is how you're going to treat her, how you might treat her. Just quickly, which of these two patients is in the higher thrombotic state? Patient 1 or patient 2? 2. Just because this patient had a bare metal stent doesn't mean she's not at risk if you take away her antiplatelet therapy. That's the point really to take home from this. It's not just about the stent. Now, if you're looking for guidelines about how to manage this, you can find guidelines. And the most recent ones are the AHA, American College of Cardiology guidelines in 2024. They also have some from 22. They're not exactly the same than these other societies. And the perspective is, is antiplatelet therapy the hero or is it the villain, right? Is it helping the patient or is it hurting the patient? And that really depends upon what specialty you practice. But it really shouldn't be, right? It's not about what the patient, it's about what the patient needs, not what our specialty is. This is, I'm an anesthesiologist, so this is what I see, in the room. The surgeon's got the gown on covering his eyes because we hate to see the sight of blood. I'm just like that because we're causing it, right? We're causing it in the operating room. No one wants to injure somebody, but the patient wants to survive. The patient wants to survive. So if the patient is going to survive, we have to, as our clinicians, no matter what specialty we come from, we should be balancing the patient's thrombotic and bleeding risks and understand what should we do for this patient at this time, given their condition, their diseases, including their surgical diseases. How are we going to get them through? Now, this is probably the most insightful recommendation I think and most from the recommendations that came out, and probably the hardest to implement. And that is that when you're thinking about what to do with someone's antiplatelet therapy, it should be a multidisciplinary decision. And it should include the patient because they need to understand if you're going to have this surgical procedure and you have this condition and we take away your antiplatelet therapy, these are your risks, these are your benefits, what do you want? There is no free lunch here. Okay? And it's better that everyone be at the table and discuss these things if you have the time than to just go and, full speed ahead and damn the torpedoes. We saw these before. Again, the last 2 points are the important, baseline important ones, that if you've had chronic coronary disease and you had a PCI, then you really should be waiting 6 months. If you had an acute coronary syndrome and you had a PCI, you should be waiting at least 12 months. That's what you should do. Now, that won't happen for everybody. Some people are going to need surgery before then. And what they're saying is you really shouldn't have, you really shouldn't be doing this before 3 months. But if you have to do it between 3 months and 6 months, you better think about what you're going to do with the antiplatelet therapy, again, weighing risks and benefits. And you definitely better not do it in less than 30 days because you've got to continue the antiplatelet therapy. Again here, if you've had a prior PCI, you should continue at least one antiplatelet agent. And you're going to see more and more patients whose only antiplatelet agent they're on after their PCI is Plavix, not aspirin. Don't stop that Plavix. Okay? There's no greater risk of them bleeding as if they were on aspirin. I know it's going to blow everyone's mind, right? But that's the way it is. Okay, and so again, it's a time-dependent process. If you need to have surgery less than 3 months after a PCI, after an ACS, with or without an ACS, really think about using both dual antiplatelet therapy if you can, but you have to weigh the risks and benefits. Okay, so in the POISE trial, looked at just aspirin alone. We talked about this before. That's the trial that said if you've had a PCI, you do better if you're on an antiplatelet agent. In this case, it was just aspirin versus no aspirin. But you see the data here, I mean, in terms of benefit, in terms of risk to the patient, there is a reduction in the cardiovascular events. There is no difference in bleeding in those who got aspirin than those who did not get aspirin, in those who had PCI more than a year ago. And so the AHA guidelines in terms of when should you have surgery. This is just a graphical display, a little bit different from the way they showed it in the guidelines. If you've less than 30 days, kind of hard stop. Don't do surgery. Don't do surgery. If you're between this, 1 to 3 months and you have to do surgery, you really should be continuing dual antiplatelet therapy if you can, or delaying surgery. If you've had a PCI and you're now in this 3 to 6 month window, again, you should continue at least one antiplatelet agent, potentially 2. Between 6 and 9 months, again, you probably at least one agent. If you've had a recent coronary syndrome in particular, you got to be careful about when you're going to do the timing of surgery. Try to delay until 12 months, and then after 12 months, you can proceed, but that doesn't mean you should proceed with stopping the antiplatelet agents. I'm not saying you should continue in every case, because sometimes the risk of bleeding is higher than the risk of thrombosis. But you should think about it. Is this case one in which the bleeding risk is higher than the thrombotic risk? How are we going to assess that? And what wasn't on the slide in the guidelines from AHA is, what do you do in those patients who've had an acute coronary syndrome and they didn't have a stent? Again, I showed you the data. Those people are even worse from a thrombotic point of view. So don't treat those patients lightly just because they didn't have a PCI. And there's this lot of gray zone again. What do you? It's all about balancing, unless the risks of delaying is worse than the risks of continuing. So comparing perioperative thrombotic and bleeding risks, what are the risks? If you withdraw antiplatelet therapy in someone who is in one of these conditions with a PCI or an ACS, the risk of MI is somewhere between 5 and 10%. Chew on that, 5 and 10%. In the year after, certainly within the year, and then even after surgery, it's about 5%. The risk of stroke is 1 to 3%. The risk of death is 1 to 2%. And that's within 30 days of surgery. What are the risks of bleeding? Okay, and these are the different types of bleeding risks: blood loss, increased wound hematoma, transfusion, infection, and then reoperation and increased mortality. Obviously, we want to compare apples to apples. We don't want to compare apples to oranges. There's a lot of bleeding events, but it's not the same as having an MI or dying. Now, when it comes to surgery, there are really high surgery procedures, right? If you're having neurosurgery, a little bit of blood in your head is a really, really bad thing. Certainly reasonable to stop anticoagulants, antiplatelet agents, in someone who's going for intracranial surgery. If you're having surgery inside of your eye, a little bit of blood's a really bad thing you may not see again. Okay, so you do have to think about, is this surgery, a little bit of blood, going to be a problem? And then there's low-risk surgical procedures, right? And there are things that are in between. This is, again, something to think about. What's worse, a bleeding problem or a thrombotic problem? These aren't surgical patients. They're patients who've had an acute MI, they are on antiplatelet agents, and they get discharged from the hospital and they're followed. And the first outcome in the top right graph is, which happens more frequently? Are you more likely to be hospitalized for thrombosis, or are you more likely to be hospitalized for bleeding? It turns out that you're more likely to be hospitalized for thrombosis than you are for bleeding after being on dual antiplatelet therapy or any antiplatelet therapy. But more important graphic is the one on the bottom. If you got readmitted for bleeding or for thrombosis, who's more likely to die? You're more likely to die if you got readmitted for thrombosis than you are for bleeding. Again, I'm an anesthesiologist. I don't like blood, but I want my patients to live. And so you have to figure out what is going to work for this patient. How are we going to balance bleeding and thrombotic risks? And I would posit to you that MI, stroke, and death, that's about the same as reoperation or death. Anything less than that is not the same. So compare apples to apples, not apples to oranges. So what does the data say about the risks of bleeding with aspirin? All right, what we know, and there's a lot of data on aspirin, is that aspirin does increase your bleeding risk. mostly by the amount of blood in the canister and the likelihood of receiving a transfusion. There is no data that says in the cases in which it's done, not neurosurgery, that you need more likely to have a reoperation, including cardiac surgery. There's no data that says if you operate on aspirin, you're more likely to die. All right? Now, dual antiplatelet therapy, I should just pause, and this is important, is that if you were on clopidogrel alone, and there isn't any data on this because we haven't seen it, then your risks are likely, based upon the data that we've seen, to be similar to aspirin monotherapy. Likely, but again, there isn't objective confirmation of that, but based upon what we have in the extrapolation. If you're on dual antiplatelet therapy, your risk of transfusion is higher and your risk of reoperation is higher, and that comes from cardiac surgery mostly. Does aspirin increase perioperative morbidity? Again, death, no. Perhaps in neurosurgery, it does. But other than that, no. Now, dual antiplatelet therapy, again, even there, from a death point of view, there's no data that says it increases risk of death, although there is some increase of reoperation. So it's important to recognize that thrombotic risks differ among patients. They're not the same, even with the same conditions that you're thinking about them for, right? Each individual has their own risk factors, and you have to think about them separately. So thrombotic and bleeding risk assessment should be done for every individual patient, and it should be done on a multidisciplinary basis, right? The team members need to get together and talk about it. If you withdraw or continue the antiplatelet therapy, it could be trivial for one, it could be catastrophic for another. They're not the same. And this should be a shared decision-making process, and it should include the patients. And then just kind of a summarization, the strategies to manage this, you need to consider, and most importantly, if you're afraid of bleeding, if you don't want to have a risk of bleeding, if you don't want to harm the patient, the surgery could do with it, and it's elective, don't do the surgery. Wait. Wait till the patient's risk is reduced. All right? If you can't wait and you need to go with surgery, then in high-risk patients, you should probably think about continuing at least one of those agents. Again, and I would put forward, based upon the data, that the risk of aspirin monotherapy and clopidogrel monotherapy is about the same. If you would have operated on aspirin, you should operate on clopidogrel. And once you've decided you're going to withhold the antiplatelet therapy for whatever time period before surgery, often 5 days, 7 days is going to be fine for an agent that's irreversible like aspirin or Plavix. Don't hold it forever afterwards. Okay, that's the real thrombotic risk time frame, because now the patient's in a hypercoagulable, inflammatory state. So you want to restart your antiplatelet therapy as soon after surgery as you can. Certainly limit that time, and somewhere between 1 and 5 days should be fine. Again, at the risk of time, I'm going to let you read the conclusions on your own, and then we will move to the next talk, where we'll talk about anticoagulant therapy.